This is the Psychcast by MDedge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcasts, Nick Andrews. And welcome to the 109th edition of the Psychcast by MDedge. I'm Nick Andrews. In this edition, Dr. Lorenzo Norris welcomes Dr. Sy Saeed for his annual analysis for the key studies that could change day-to-day psychiatric practice. The conversation is centered around a two-part evidence-based review that identified the top 12 research findings for clinical practice between 2018 and 2019. You can read those in their entirety by clicking the links in the podcast notes. And speaking of notes, before we get to the interview, this show does come with robust show notes courtesy of Dr. Jacqueline Posada, as always. The notes include relevant links as well as an outline of the information discussed in this episode. The Psychcast acknowledges the extraordinary circumstances of COVID-19. We would welcome any ideas or suggestions regarding topics or guests as they pertain to clinical psychology and psychiatry, as well as any pearls or anecdotes related to the pandemic's effect on mental health. You can get in touch with us with your pearls, anecdotes, or ideas by emailing us at podcasts@mdedge.com. Okay, let's get to this week's interview. Please welcome the host of the Psychcast, Dr. Lorenzo Norris.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of NEJM Psychiatry. Welcome to today's Psychcast. We're privileged to have Dr. Saeed joining us today, and he's going to talk with us about his recent work in looking at research articles, more importantly, the top 10 research articles that you can actually implement clinically now in your everyday practice. When I first came across Dr. Saeed's article in Current Psychiatry, I was impressed by the applicability, that it tackled many issues that I myself still struggle with or my colleagues struggle with, and having guidance that we can actually implement right now was just very useful. So I'm so happy that Dr. Saeed can appear with us today on today's Psychcast. Dr. Saeed, welcome.
Thank you. Happy to be here.
Now, Dr. Saeed, the average clinician, all of us face enormous if you will, demands on our time, whether it is from work, whether it is from CME, whether it is from our own family life. We face exceedingly challenging patient situations. And let's at least not forget, in this current environment right now, we're in the midst of a COVID-19 pandemic. So time is truly of the essence. And I was really impressed with the article in terms of looking at top 10 research articles that can impact clinician, if you will, care right now. I was wondering if you could inform us or let us know what was your methodology in looking at and how you actually determined which articles could maybe be of best benefit to clinicians.
So day-to-day clinical practice, we face a lot of challenges, one of which has to do with recognizing that the current best evidence about a given treatment must be considered and applied to clinical practice, at least wherever possible. The challenge becomes that how do you locate this current best evidence, what's reliable, what's ready for clinic, and what's still at the bench level, and many things related to that aspect. So we live in times when information is being generated on a day-to-day basis with such a speed that the knowledge is growing faster than ever. And currently, there are people who would estimate that the doubling of knowledge for biomedical sciences is somewhere between 2 years at the low end to about 8 years at the high end. The challenge of our time is that and we ask ourselves is how much information in our midst is useful. And related to that is how much of it gets in the way. In other words, there is so much noise in the literature that comes out that sometimes for a busy clinician it becomes very, very difficult to actually tease out what to take home and what to basically disregard. So with that in mind, and I've been studying the field of growth of knowledge for some time now, and dealing with that question. So what I've done for the methodology for these articles like this, and I've been doing that for over 10 years now. It started as a presentation for the Psychiatric Association annual meeting. So with this, first, it's a three-pronged methodology. So first, I would start with a primary literature search and look at the studies that have come out during the last year. And the time used for that is usually July 1 to June 30th of the preceding year. And so that's number one. I would look up the literature and find out what are some of the important findings which are ready for the clinical implementation. So this is not about the bench research, the foundational studies, the basic science findings, which are all very, very important. But if they are not ready for clinic, they don't go into this compilation. The second one is to take the bias out, because this is one individual doing the search. There is a survey that would go out to various organizations that include American Association of Chairs of Departments of Psychiatry, Group for Advancement of Psychiatry, American Association of Clinical Psychiatrists, American Association of Psychiatric Leadership, North Carolina Psychiatric Association, that's the state I'm in, as well as many other people that I know from academia who are in the business of knowledge creation as well as clinical. So that's where it would go. And the question of the survey is very simple, very brief. It basically asks them, quote, amongst the papers published in the period July 1 to June 30th of the previous years, which ones, in your opinion, have or likely to have or should have impacted, changed the clinical practice of psychiatry, unquote, end of the question. So this way, people would nominate papers that they think have changed the practice of clinical psychiatry, and I would get these nominations. And the third step is where I would go to the secondary literature. For example, Faculty of 1,000 Factor, Cochrane Review, New England Journal of Medicine, Journal Watch, publications from the American Healthcare Administration and Research, or Agency for Healthcare Quality now. So these are the secondary literature where they are looking at many of these studies that have been done. Now, ideally, if there is a concurrence between all these three sources, in other words, that I have found that a study in my own search, somebody in the survey have nominated that study, and in the secondary literature that has been appraised as high quality evidence, that would be the ideal. And that would basically lead to generation of a list that would become the top 10, or many times it's more than 20 articles, but usually never more than 20. So somewhere between 10 to 20, which would create the list. And there's the starting point of the article as well as the presentation.
Okay. Well, there's a number of things that I really like about the methodology. When I'm, as a practicing academic psychiatrist who works in outpatient hospital settings, this is always a challenge to whether you're speaking to trainees or whether you're speaking to junior faculty. I will, at times, folks will want to present a research article to me, or they will present something on, for instance, the genetics of schizophrenia. And while that is very, very, very interesting, they're still not actually able at times to answer like the basic question of, well, do we have evidence in terms of whether we should use this combination treatment or not? Or how is this actually going to impact care now? Not that it's not relevant, but when we have a patient in front of us, we have to make sure that our research, if we want to know the evidence, but if the evidence that we're bringing up in the midst of a busy clinical day, we want to know what evidence is actually going to change management, and as I like to say, move the needle. And that thing with, as you mentioned, about signal to noise, is hugely important. And how when you brought up those other three, your methodology, I almost think of, I kind of draw a triangle. It's almost like triangulating knowledge. You know, you have three different, if you will, sources, and then if all of those line up, you have like really located what is going to be implementable and what is going to be usable in the day-to-day practice. You had mentioned in regards to the doubling of knowledge, which, you know, we are aware of, but also I wanted to hear a little bit more in terms of your perspective as a psychiatric chair and the value of clinicians having, for lack of a better word, those top 10 or 15 studies right at their fingertips, that they can either work with, whether they're training others or whether they're taking care of patients. And frequently in this day and age, patients have a lot of questions. Everything is just Googleable away. And people have a lot of questions, and I want to know, from your opinion, how do people under your guidance use these tools in your own institution?
So one of the things that this has been used quite a bit in my department is, as you know, every department of psychiatry and training program has a journal club, as well as grand rounds required of the residents. So this has actually provided them with at least a list that they can go through to choose and select an article which one to present. Because the goal or the objective of generating this list is basically to help reduce the gap between science and practice. So they utilize for that because they know that this is a high-impact article with some take-home messages that could be applied to the clinic on a day-to-day basis. Whether it actually impacts that gap is an empirical question that obviously hasn't been studied, but it basically brings that list to their attention. Another thing where some of my residents have actually made comment on that, which has been very gratifying to me as someone who spent a lot of time working on this, that they would come and they say, well, you know, nowadays people come prepared with information. It's interesting that the information they bring to me in printout. But through this methodology and the process, and now getting used to the concept of the noise to signal ratio, they have started to realize and actually have been communicating with their patients that just because it's out there doesn't make it a fact. And there's a lot of noise out there. So to say, well, you know, how did you get to choose this one, aside from the fact that it was appealing to you? So in a way, this is modeling for them that there may be a lot of information out there, and it's important to be a critical appraiser of all of this information and get to the core body of knowledge or signal there that they can say, yes, I can rely on that. The third thing that I've noticed and I emphasize in my teaching and when I present is that while I'm presenting this, I have a slide that has just one sentence on it in very big, bold letters, and it says, all knowledge is provisional. Because what we know today is likely to change. So whatever we find out today, although it may be a major finding asking for a major change in our practice, it's quite possible that tomorrow we may run into something different. And it's not because we are just completely wrong today. It's just how knowledge happens and how science progresses. And in just my career, I'll give you two classic examples of that happening in one career. And so when I was a resident, ready to embark, that was a time that the first atypical antipsychotic since Clozaril comes out, risperidone. And at that time, the question was that, of course, it's a dramatic change in the field. People are excited. And at that time, when you studied some of the pivotal study findings of the thing, the major concerning side effects were not metabolic syndrome or things that we know today. It was things like nasal stuffiness and things like the GI upset. And somewhere a few years down the road, it became almost established as a fact in the field that atypical antipsychotics were the drug of choice for negative symptoms and cognitive impairment. So when patients were being seen with negative symptoms and cognitive impairment, choosing atypical over typical became the standard of care and part of the guidelines. And we know today that that's not the case. And basically, in terms about the cognitive functional improvement and negative symptoms, both typical and atypical are about the same in their level of efficacy or lack thereof. And lastly, when Prozac came out, fluoxetine, the prevalence of sexual dysfunction was less than 5%. Mm-hmm. And so these are the kind of things that our hold on truth is always partial, and knowledge changes. So all of these things, when we generate a list like this, it's said with, this is what we know today, and this is what we have an obligation to use in our clinical practice because we are supposed to be providing to the patient what science has promised them. With a good possibility that tomorrow some of these things may change.
Okay. Dr. Saeed, on that note, with that all knowledge changes, have you noticed any themes or principles that you or other chairs and departments utilize to let you look at a study and you say to yourself, you know what, this is something that's relevant that can be implemented now? Is there anything that our readers, if they're at home and they're reading something, is there anything that you look for that just jumps out and lets you know, like, you know what, we could use this right now?
Well, so it's that's where I find the secondary journal to be of really, really great value. So with this primary literature where all the studies get published is exciting. So you find something which is likely to change medical practice the way we know it today is very exciting. But you are still left with the question, well, is this a large enough N? Was that a sample that is similar to the patient population I treat? And of course, the bigger question is always that studies of efficacy are not the same as the study of effectiveness. Because when we have excluded so many patients from those studies, it becomes almost very, very challenging, if not impossible, for me to take it and say it's a generalizable piece of that. So primary literature would get me excited, but it's the secondary literature where finally all these signals start to converge that I start to see the signal emerging out of that noise, if you will. So that's the exciting piece of there. So clearly new findings are the one that everybody gets excited, but is this a new finding that I can apply today is the one that we are looking for.
Okay. Dr. Saeed, can you tell us a little bit more in terms of just define a little bit when you say secondary literature, what are you speaking of, sir?
So secondary literature is the one where they would pick up several of the articles and start to do whether it's a meta-analysis or trying to come up with themes or where things converge. So the examples of this are, so of course the classic example have been the Cochrane Review. So they would pick up a question and they say, so we have looked at 100 different studies and that's the bottom line of that. Or Essential Evidence Plus or BMJ Best Practice. In mental health, the evidence-based mental health is one of those examples. And of course, New England Journal of Medicine Journal Watch, and there is one in psychiatry. They would pick up those articles. So this is like someone who has picked up the original literature, the primary literature, and actually either compiled a lot of them to find the signal, or if it's a major finding by itself, then they have picked up the article and offered a commentary on that.
Okay. Now, Dr. Saeed, again, we've talked about the methodology, how we go about it, maybe some different things that people can think about in regards to how they're reviewing literature themselves and how to figure out, again, with that theme of how do we separate signal from noise. Are there any, from your most recent work, are there any current examples of like burning questions or clinical things that have been on either your mind or chairs' minds that there might be some answers out there that can that our listeners can benefit from if they read some of the literature that we're referring to, or that we will probably reference your article at the end of this podcast?
Sure. So thank you for asking that question. So some of the pertinent questions are, for example, the question of antipsychotics causing sudden death in patient, especially older patient, has been a well-established finding for several years now, and it's been well investigated, and many of these drugs now have a black box warning. As clinicians, we are aware of that. We have also seen in recent years a rise in the number of antipsychotic prescribing to young patients. So whether it is for pediatric bipolar disorder or autistic spectrum disorder or intermittent explosive disorder, we see the prescription of these drugs are on a rise. And the question then comes up that since the newer medications tend to have fewer side effects or different kind of side effects compared to the older one, our threshold for prescribing over the years has changed, and these medications are being prescribed very, very often in the primary care circles. So one of the studies that was picked up by this methodology was a study exploring exactly that question, which was a large retrospective cohort study amongst children and young adults from age 5 to 24 who have received these antipsychotic medications. And basically the question was, would we find a similar increase in the risk for sudden death among young patients? So that's very pertinent to the day-to-day practice. Two other examples that I would describe here is, so we know that polypharmacy in psychiatry is frowned upon and have been seen as a bad thing for a long time. And sometimes people would say, well, our colleagues in cardiology and internal medicine don't seem to think of that. And actually, it seems to be a common practice, for example, for hypertension or many other diseases for people to get more than one antihypertensive. And so why is there such a bad thing in psychiatry? So that's one thing. The other question that has always come up is that while most of the major treatment guidelines would advise against using polypharmacy, so use of 2 or more antipsychotics for the same reason, but when you survey clinical practice, it is quite common that patients are on more than one antipsychotics. But the question has not been looked at in some kind of an extensive fashion. And another study that we reviewed and was picked up in this survey was a study to look at when patients who are on 2 or more antipsychotics for the same diagnosis, was there any change in their symptom exacerbation requiring hospitalization? So the question is that did that polypharmacy reduce the number of them showing up with an exacerbation and ending up being hospitalized? And a third one on similar to that question is that prescribing adjunct or augmentation agents along with antipsychotic also tend to be a common practice. But the question that has not been answered satisfactory level was, well, how does that change the outcome? So there's another study that was included in these top 10 list looked at those augmentation agents. So for example, adding an antidepressant or a benzodiazepine or an anticonvulsant. And interestingly enough, adding an antidepressant actually enhance positive outcomes, whereas benzodiazepines did not. Actually, those worsened it. And some of the anticonvulsants actually they didn't cause any harm or didn't enhance the outcomes either. So those are just some of the examples. Another example was use of, for example, prazosin for nightmares associated with post-traumatic stress disorder is a common practice now. And there have been smaller studies that have suggested that they usually would improve those nightly nightmares, especially if the patient has improved in other dimensions of PTSD, but nightmares had not improved. The smaller studies have all validated that. And so to replicate that, a very large study was done, or a significantly larger study was done to look at that finding. And interestingly enough, it did not replicate the findings of the smaller studies. Actually, it showed no significant change. Now,
I wanted to just comment right there as you were talking, Dr. Saeed, because the prazosin article was one of those that actually really got my attention, and I think that's an example of knowledge expanding, clinical practice changing rapidly. I won't even say rapidly, but certainly over 10 years, because I remember as a resident, or even definitely recently, the prazosin certainly being, if you will, a commonly prescribed agent for this indication. Now, I'm not telling clinicians one way or another what to do, but what it does is it starts to arm you. It starts to give you a little bit more practical information that, and when I test this, am I going to use this I use this on a day-to-day basis with probably a majority of my patients, or will I have to think about this? And that article is absolutely an example of it. The other one, the other themes that you talked about, particularly polypharmacy and the use of adjunctive medications, has been not just on my mind, but on a number of clinicians' mind for quite some time. When I think of polypharmacy, probably the first thing that comes to my mind is, yes, I've been taught clearly polypharmacy has been frowned upon in psychiatry, but the term I would actually, and I want to say my attendings and others have taught me this, is can you actually have rational polypharmacy? Like, does the polypharmacy make sense in terms of what you're doing? In that case, you at least can justify, but frequently at times we'll see now, or at least I will, I can't speak for other clinicians, you'll see just, if you will, just a prescribing, just constant prescribing, and then you'll get a situation, and sometimes to segue into another theme you have, you'll get maybe young adult patients that may be on 3, 4, or 5 medications, have a number of side effects, and you can't really figure out, the patient can't explain it to you. You have to tease through how exactly did they get on all of these medications and what actually is working and what isn't. But then you face the problem of, if you will, tapering them off of those medications and not knowing how they were started, and the patient destabilizing but not necessarily wanting to be hospitalized. So I felt that all of those examples, I'm just talking right now just off of, I could pull up practical examples from this, from just what you said, virtually in my practice, outpatient, inpatient, every single week. And these are the burning questions that are on people's mind that we really want a lot of signal and not a lot of noise with.
Right, yeah. And then you said the key word, rational.
Yeah.
And what happens is when we are busy as clinicians running in all these different directions, it's a busy day. What ends up happening is that once we have gone to a level of some improvement, many times we tend to put up with that, and many times our patients put up with that. And usual answer is, well, yeah, I'm not quite there, but you should have seen me before this medication was started.
Yes.
And at that time, most of the rational thinking and everything goes out of the window, because we are doing what someone has described as putting up with partial success.
Yes.
And things keep on getting added. So the big question is that there may be a time, your other point, we added something and got the result, but when would we think about taking it off the list? And if we are adding something, is it time to take something off the list? So always looking at this, and because we know that with many of the patients that we have, they are chronically and persistently ill. and things keep getting added to the list. And by the time they are in their 40s and 50s, and they start to get other chronic general medical conditions, it's not uncommon for them to be on over a dozen medications.
I agree with you completely, Dr. Saeed. And I think one of the things, again, you talked about that primary analysis and secondary analysis. One of the things that I found useful with patients, because at the end of the day, it's about relationships, and it's about whether or not your patient really trusts you. And I frequently get the question, from patients, did you read this article, Dr. Norris, or did you read that article, or did you read this? Mm-hmm. And I will look at them, because I was taught a long time ago to just be honest. I was like, no, actually, I didn't. There's no way humanly possible, even with Journal Watch, even with Current Psychiatry, even with take your pick of with Medscape, any number of sources to keep up with every single, if you will, article that is out there, because there are a number of clinicians putting out excellent work and really trying to figure out these questions. But what I can do, if I work with my colleagues and get some assistance, which is why I really loved your piece, if I have maybe 10 articles that are in my toolbox that I can use to help me understand and explain a lot of articles, some of which are signal, but mostly are noise, then I feel like I've generated trust with my patient. And my patient feels it also, because I'm not just saying I didn't read it or it's irrelevant. I can actually explain to them why I'm using this particular article and what it helps me do to understand the articles that you are presenting. So, and you go into the idea of like, as a patient, I want you to know what are the common questions that you're going to have and that we have to answer as a team. So again, when I look at articles like that, I do think about like how could I use this article in terms of building a relationship with a patient, as well as understanding any other potential piece of knowledge, well, I won't say knowledge, or information rather, that a patient could bring to me. And those examples that you brought up, which have been there for quite some time now, polypharmacy, combination therapy, use of 2 or more antipsychotics, amongst other things that you brought up, have been there for quite some time. So, yes.
Mm-hmm. Mm-hmm. Yeah, you said the key word, and I really like what you just described about things happening in the context of a relationship. Mm-hmm. And you are saying and doing things with that explicit or implicit goal. Because I believe in relationship being the foundation of just about everything positive that happens. And as someone growing up with the psychodynamic tradition and training, I also happen to believe that even for the medication use, so even when I'm doing nothing but psychopharmacology, if it's not happening in the context of the relationship, you don't get the same results as you would when you have that relationship.
Absolutely.
And it also makes it easier to make those changes, because time and time again, when I present something to the patient as a potential change, they would resist. And if they have that sense that overall I'm here and have been with them and in general have been helpful and have done things which have been helpful to them, they are more likely to accept that suggested change, as opposed to someone just coming in and saying, although this combination has been working for you, to some extent, I would like to change that. And if they don't have that trust, that overall this relationship has been positive therapeutic alliance, and things are likely to happen to their advantage.
I agree with you completely. The other thing in this is going to be tough. I would say this is going to be tough for clinicians, but I would challenge my fellow clinicians out there, as well as mental health providers that might be listening to this. And I'm not sure what their patient panel is like. I realize there are people there that are fee-for-service. There are people out there that are accepting insurance. And there are people that are working in clinics. There are people who are working in hospitals. It runs the gambit. But what I would encourage you to do, even if it's not your whole panel of patients, maybe it's a subset of patients. I would like for you to take those patients, put them in a list, and just if you read Dr. Saeed's article or an article similar to it or something of that nature, but I highly recommend Dr. Saeed's article, I want you to look at those questions or those problems that are trying to be solved by the authors of those papers, and then I want you to look at your patients and just go down the list and say whether or not your patient is dealing with this and whether there's something you can change. Just do that simple exercise. Whether it's polypharmacy, whether, take your pick. Just do that simple exercise, and if you start making a lot of check marks, maybe that's an area where you can make a change in your patient and see if it has a result. So again, but the key thing for me is you have to actually not only take the information, but apply it to your patients in the here and now, and tell them why you're doing it, and get them to collaborate with you. And yes, I will. Our departed colleague Carl Bell said it best. I mean, we ask the hard questions, and I'll add another thing: we roll up our sleeves and we do the hard work. I'm not saying it's easy. I'm not saying it's an easy thing to do, but if many of you right now, in the midst of this pandemic, are in the midst of telehealth, and I hope you folks had an opportunity to either listen to some of our Psychcasts on telehealth, or look at a lot of the excellent guidance out there by the APA or maybe your own institution, you might have some more time on your hand because you're not spending a lot of time commuting to work, and you can actually go through your panel of patients and actually see, wait a minute, am I practicing not only evidence-based medicine but impactful evidence-based medicine that I can make a change right here and right now, taking advantage of kind of the circumstances that are in place for us right now. So again, when I think of Dr. Saeed's article, I think of that's really that was my inclination. That's what, after I read the article, that's immediately what I wanted to do. I'm like, wait, let me just go down my panel and look and see what am I doing, because as clinicians, we're so busy, we frequently don't have time to think or delve deeply the way that we want to. So it's important to have articles like this that do a bit of that initial legwork for us, but we still got to take it the next step. We still have to take it the next step. So Dr. Saeed, I really want to thank you for speaking with us and giving us a lot of food for thought, not only in regards to your approach to papers, but just your philosophy in regards to medicine, and how and I appreciate you speaking about how we ultimately, as we always do, use this to collaborate with our patients in the treatment healing relationship, if you will. But Dr. Saeed, I want to any last words or thoughts that you have for our listeners today, sir?
Well, first and foremost, I really appreciate the invitation to have this conversation with you, and I learned things in this conversation for which I'm grateful, but I'm thankful for this opportunity. The last thing I would say is, which is sort of my disclaimer, that the notion that what I have in this paper, that these are definitively the quote-unquote top papers, I cannot defend that. It's likely that others who would do their own search would find different papers or choose different ones. But my main point is as follows, that these are papers of high quality with direct clinical application. And if we use this information prudently, it will enhance our practice, but more importantly, they are likely to generate better outcomes for our patients and their families.
Dr. Saeed, thank you so very much for appearing on the Psychcast, and looking forward to speaking with you further in regards to pretty much anything, whether it's psychodynamics or if we're really trying to think about perhaps research and how it really impacts our patients. Thank you so much, Dr. Saeed.
You're very welcome, and thank you for the invitation.
And that concludes the 109th edition of the Psychcast. I am Nick Andrews. Let's get to this week's credits. The Psychcast is produced and hosted by the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris. Our guest this episode was Dr. Sy Saeed. The show notes are authored by Dr. Jacqueline Posada. The show is produced by MDedge editors Gina Henderson and Jeff Bauer. All MDedge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Aransky, as well as MDedge executive editors Mary Ellen Schneider and Kathy Skarbeck, along with multimedia editor Terry Rudd. Psychiatry Social Media is produced by Kyla Clark. I'm your audio editor, audio engineer, and the voice of all MDedge podcasts, Nick Andrews. This is the Psychcast.